This is from the Apollomedics Super Speciality Hospital. I, Dr. Gautam Swaroop. We are live case in box for this case. The case history is he is the 65-year male with some neuropathic component on the left side, and he is having hypertension and COPD with the active component. He was having the history of the dyspnea on exertion and recurrent presyncope since couple of months, and he was diagnosed severely calcified aortic valve outside, and then he consulted to this center. When we have done the echo, it was shown that the severe calcific AS, mild AR, mild MR, and ejection fraction was decreased. It was 35 to 40%. Creatinine was normal. We discussed with the heart team, with the surgeon, and we decided to go ahead with the percutaneous therapy TAVR. So if you see the echo, it shows that the global LV hypokinesia, you can see the velocity, aortic valve velocity is the 3.59, gradient is like this. I think it is low flow gradient. So if you see the ECG shows the normal sinus rhythm, LVS, there is no bundle branch block. So we are expecting that we will not disturb any conduction system during the procedure. So if you see the aortic root analysis, so if you see the annulus, the area of this annulus is the 456. So with the area 456, we calculated the possible valve sizes. So we have come out with the three options: 23 millimeter valve, 24.5, 26 millimeter valve. We have chosen the 26 millimeter valve because this valve is tricuspid valve. We expect to increase 16.3% oversize, but somehow the annulus calcification is not up to the mark. So we are expecting to add 1 or 2 cc more to grab this valve to just avoid the pop out. Again, we are choosing the my valve in this particular case. Either way you can choose any self-expandable valve as well, but in this particular case we have chosen the my valve. So if you see the annulus, and we have discussed that if you compare the annulus with the LVOT, the anatomy is the tubular. If it is a narrow anatomy or it is like LVOT is more than the annulus, so the risk of embolization is more. But in our case, the anatomy is tubular, so we are not expecting any kind of the embolization or any other consequences. So if you compare annulus with the SOV diameter, SOV diameters are good. It is all the SOV diameters are like 37 and 34 and the 33. So SOVs are very roomy. So we are expecting that our valve leaflet will perfectly lie on the SOVs, and there is less chances of the coronary ostial obstruction. So if you compare if you see the coronary heights are again very good. It is the left coronary height is 18.6 and the right coronary artery is 19.9. So again the coronary heights are pretty good, and we are not expecting any kind of the coronary obstruction in this case, and we will not going to take any kind of the coronary protection. Again, if you see the sinotubular junction is again more than annulus. So again we are safe at this point. Our stent frame will not going to injure the STJ. And similarly with the aorta is like 35 millimeter, so it is not dilated aorta. So again we are good with the aorta. So if you talk about the calcification, we know all that the calcification is a very important part of the planning. The calcification is divided into the annular calcium and the leaflet calcium as well, but somehow annular calcium is not pretty much high, or it is mild kind of the calcium, but again the valve leaflet has the calcium itself. Again there is a chunk of the calcium which is extending into the LVOT, but again this calcium, if you see the pattern of this calcium is on the inner border of the LVOT, it is not protruding. So we are not expecting any kind of the annular injury or any kind of the chances of the paravalvular leak. So this is the calcification on this thing. So if you see the deployment angle, definitely we are going to deploy in some epicranial kind of view. It is RAO3 and cranial 3, it will be our deployment angle. And if we want to go in the cuspal overlap view, it is RAO caudal view, it is like 25-18, but our implanters view will be the RAO cranial. So this will be our angiography angle. and you can see the calcification which I described next. So, the basic discussion is that we have to basically physiologically match the transcatheter heart valve to the normal anatomy of the cusp. So, in the tricuspid valve it is very important to understand the commissural alignment. So, here is the 3 figures in which you can see that we have measured the angle of the commissure, and it is like 3 o'clock, little bit it is the angle is like 89 degree. So, if you see the crimper, the middle image is the crimper, we will show it the live how it is crimped, and it is crimped like this way, and the angle would be like 89 degree, and we will show you. If you see the peripherals are good, and it is quite roomy with the no calcium. So, we are expecting that we will not harm any of the peripheral vessel, we will go smoothly, there is no calcification at all. So, we have this is the iliofemoral analysis. So, this is the analysis of this this Three-Menshow report. On the basis of this we will proceed, and Dr. Shoaib is going to just show you the echo. So, as you can appreciate, this is moderate to severe aortic stenosis, the aortic velocity is like 3.8, and this is the mild AR is there. Can you show the color? So, as you can appreciate, there is a mild AR in this particular case. Either way it will help us to guide the wire in the aorta, valve crossing it will help, and again it is the mild MR. So, we have chosen the left femoral axis, and we give the injection to just delineate the femoral bifurcation. Next please. So, we put a V18 wire into the iliac artery just for the protection or any kind of the complication if it occur in the dissection or something else. So, we prophylactically put the V18 wire. We put the temporary pacemaker from the upper side. So, till now we are here, and now I am going to we put the pigtail at the non-coronary cusp, we are going to take the injection, and simultaneously I am going to upgrade the sheath. We place this sheath here, and now we are going to cross the valve with the AL1. So, as you can see, there is a central jet coming out from there. So, possibly this will be the area to cross the valve. Coronaries are good. So, we are going to cross the valve with the AL1. Yeah. So, we have crossed the wire with AL1 and the Teflon straight tip, and then we took the pressure gradient, and you already seen on this thing. Then we exchanged the extra small length safari wire to the this pigtail, and now we are till here, and now we are going to demonstrate how the valve has been crimped, and how it is going to do the commissural alignment.
This is the valve. As it has been stored into in gluteal aldehyde, we need to wash it thoroughly in 3 different bowls. That is the valve. These are the 3 commissures, and we will be trying to achieve commissural alignment with a special technique. we derive an angle on the CT on which we decide where the commissure post of the valve has to be crimped, in which angle. ये डायल है और ये अंदर जो लीफलेट का जॉइंट है उसको फोकस करना है. इट हैज़ टू coincide at 12, and then our delivery system has got this Merrill printed on the hub. We will be keeping this Merrill up, keeping the Merrill facing up, and the delivery system straight. Will crimp the valve on the balloon. After the crimping, we have not changed the angle of the commissure. We get the small dial to cross check again before we finally crimp. So if you see, this white post is again the commissure post, and exactly it is at 12. So we are good to go for final crimping. That's the crimped
So
valve.
I hope you got the demonstration of the commissural alignment. Why commissural alignment is important? Because commissural alignment get the physiological replacement of the valve, because commissural alignment leads to the securement of the coronary aperture. If in case of the future any coronary obstruction, we can get the coronary access as the physiological leaflet. So that is why the commissural alignment is important in the tricuspid valve, and the coronary alignment is important for the bicuspid valve. Please, we are going to ready to take the valve up, please. घुमा रहे हो क्या? नहीं बिल्कुल. Grab fluoro. Now we are about to cross the valve, and we have crossed. Yeah. Save it, please save it. 220. Pressure is going down.
Ready.
Ready.
हो गया 40 से नीचे हो गया.
Pressure is below 40.
Yeah, going. 3, 4, 5.
Down. Disconnect.
Apical pipe chamber view. There is no regurgitation or
There is no
parabolic.
regurgitation. Yes.
Maximum gradient is 4 mmHg.
4 mmHg. That's good. The velocity is 1.04 and the mean gradient is
Is
4,
4.36.
4.36. I think we are good. So there is no paravalvular leak as well. So again, we are pretty satisfied with the echo findings. So as you can see, there is hardly any gradient. There is hardly any gradient between the aorta and the LV. Perfect. So we are perfectly done this transcatheter valve, my valve, and there is, as you can see, the valve is perfectly placed. There is no AR and all these things. So as you have, we have discussed the case history of that patient. That patient was a severe aortic stenosis, low flow, low gradient type of patient. So we took the two axes. One is the right femoral and the second one is the left femoral. Since the patient is having some neurological problem is the left lower limb, we put the temporary pacemaker from the subclavian. So we took the IMA catheter and give the chute to delineate the bifurcation. This is the chute. Next, please. So we put the V18 wire just for the protection of the arteries in case of any dissection. Next, please. We have got the puncture just on the level of bifurcation, and we took the pigtail and we placed the pigtail at the non-coronary cusp. So next we upgrade the sheath and then we put the python sheath, and you are seeing the python sheath is going up. Yeah, that you are seeing that the python sheath is going up. Next, please. So we put the pigtail, take the chute, and you can see that there is a central AR and as we are predicted the anatomy on the 3-man show report, it was as it is. So, after that we took the AL1 catheter and we tried to cross the valve with the Teflon straight tip. Kindly show the wire crossing. Previous run. Yeah. It took some time, but give the fast forward. Yeah. Do the fast forward. Yeah. Do the fast forward. 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 Go, 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 go. Go, go fast, go fast. Go next. Yeah. So, at this point of time we were succeeded with the valve crossing the Teflon straight tip wire. Next please. So, we exchange the regular Teflon wire with this AL1. Next please. So, we exchange with the pigtail. Next please. Take the gradient and then again we exchange this pigtail to the extra small safari wire. This is the valve delivery. This is how we cross the valve. We did not pre-dilate as it was there was no calcium, so we decided not to pre-dilate this, and again the LV function was low. So, this was the valve positioning. We deployed this valve as the 80-20 level. This is the valve deployment. We deployed the valve. Next please. So, this is the after the valve deployment we took the check shoot again, and valve was perfectly aligned. There is no coronary pinching, there is no paravalvular leak, there is no AR as well. So, this is till now. There is little bit of probably the left bundle branch block is being developed, but again I do not think it is a matter of concern. So, now we are going to give the heparin reversal, and we are taking the this sheath out and deploy the ProGlide. Now we are deployed the ProGlide perfectly. So, now this is all about the procedure. Peripherals are okay, and now we have successfully done with the my valve, and I am thankful to all my colleagues, Dr. Radesh, Dr. Shoaib, Dr. Sarkar is cardiac anesthetist, chief technician Gopalji and all. So, I am thankful to all of you for this successful case. Thank you. Thanks again.